Hey, CE Impact subscribers, welcome to the Game Changers Clinical Conversations podcast. I'm your host, Josh Kinsey, and as always, I'm excited about our conversation today. Headaches are one of the most common health complaints, but their management can be surprisingly complex, especially when distinguishing between primary and secondary causes. In this episode, we'll explore evidence-based strategies for treating headaches and discuss how pharmacists can play a pivotal role in improving outcomes for patients struggling with this challenging condition. And it's so great to have Allison Martin with us today as our guest for today's episode. Allison, thanks for joining us.
Thank you so much for having me.
Yeah, we appreciate you taking time. She's in her clinic setting today. So again, taking time out of your busy schedule, and we're very grateful. So thank you so much. Before we jump into our topic for today, Allison, I will let you kind of introduce yourself to the learner. So take a couple of minutes and tell us about yourself, your practice site I referenced. And I always like to let the learner know why you're passionate about today's subject. Why have we brought you on for the episode? So you
Great.
go, Allison. Yeah.
Okay, great. Well, thank you again for having me. So, I currently practice in the ambulatory care neurology clinic at the Ralph H. Johnson VA healthcare system. And my role here, I've been in this role for 10 years, almost 10 years. And we developed a pharmacist led pharmacotherapy clinic for comprehensive medication management within the neurology practice. So, how my practice works, patients get consulted to the neurology service after they've seen the neurologist, had their diagnosis established. If a need is identified for more fine tuning of the medications or closer follow up on medications, then they are referred to my clinic. Using my scope of practice, then I'll work on those medication adjustments. Hopefully, we'll get them to a place where we're meeting patient and provider goals, and can send them with continued care. So, my consults are quite diverse within the general neurology practice, although about 50% of my consults, year to year, have pretty predictably been various headache disorders. It is
Mm,
certainly one of those neurologic conditions I'm very passionate about. I have somewhat of a personal connection. My mother suffers from migraines,
mm,
and especially later in life, she's had quite debilitating challenges. So
mm.
it's been an area that I've been personally passionate about, and I
Yeah.
think is such a great area where pharmacists can really work at the top of their license and offer support across multiple practice settings.
Yeah, no, that's great. And what a great resource for your mom to have the headache expert there to kind of help her through the process as well. So, yeah. Well, thanks again, Allison. We're so excited to have you and for you to share your expertise and your knowledge on headaches with us today. So, without further ado, let's jump into our content. One of the things I always like to do is to ensure that we're kind of just laying the foundation for the topic for today. So let's just kind of take a step back and just reiterate and discuss again just the prevalence and impact of headaches. Like, what is this doing to our patients, the impact on their quality of life? Like, obviously, you see this firsthand. So just kind of let's set the stage and just kind of everybody go back and remember what headaches are, how they're classified, and how they impact others. So,
Right, absolutely. I mean, pretty predictably, this has been one of the most common neurologic conditions that we see. And I mean, even worldwide, recent reports have been over 3 billion patients suffering with headache
wow.
disorders. And you think about a lot of these headache disorders and when they often present and are most common, you're thinking a lot of younger individuals, times when
Mm,
they are working, and so the impacts you can see, not just on the healthcare system and utilizing healthcare resources like the emergency department or urgent care visits, but also on the patient's productivity, days away from work, their impact on ability to function, their quality of life. So it certainly is a significant condition that can have a lot of impacts. You
yeah.
mentioned, kind of diagnosing or characterizing the different headache types. And I think we'll
Yes.
get into that a little bit more later. And that also becomes quite an important consideration as we're stepping down this pathway, thinking about treatments and different recommendations.
Right, because that, I mean, obviously isn't going to inform which path you take based on the management of what is classified as, right?
Absolutely.
Yeah, yeah.
Absolutely.
Those numbers were mind blowing. Like that is a lot of people that suffer from headaches. And
Right.
you bring up a great point as well in the fact that it's not just the quality of life of the patient that it's impacting. Obviously, that's important, and that's one of the things that we want to try to affect with the managing it as a pharmacist. But it's like you said, the missed work or the missed productivity or the fact that they maybe can't drive because of debilitating headaches. And so therefore, then they have difficulty getting around, running errands, getting to work, that kind of thing. So just a
Right.
lot of things can kind of blossom and grow from just a headache diagnosis that really affect and impact not just the patient's quality of life, but everything around them. So yeah, that's a great point. Something I don't
Absolutely.
think yeah,
One thing
didn't really realize. Yeah.
I'll add too that I always find interesting, it's a disorder that many also self-treat and manage
Mm,
over the
mhm.
counter. So even
Sure.
some of those numbers we may not have complete and
Right.
accurate assessments, and it may be more prevalent than we
Right.
know.
Exactly. Yeah. Because I mean, how many times do you say, "Oh man, I have a splitting headache," and you just, pop a couple of pills, and at home, and
Right.
it's, not anything that you actually get follow-up care with or be officially diagnosed with something. So yeah. So let's talk a little bit about well, I think it's a great way to kind of go into it. Let's go and set the stage for what are the different types of or the different classes classifications of headaches, just so that we can kind of know. We don't have to go into great detail there, but it'll kind of help inform the decision as to how we're talking about the management of them later. So,
Absolutely. Well, usually we start pretty broad based in classifying either as a primary or secondary headache. So, secondary headaches, you kind of think in secondary nature to something else that has caused
mm,
this. So, this could be post traumatic headaches if they've had a history of head trauma. This could be cervicogenic headaches. This could be one of the most common ones that we may encounter, especially as pharmacists, is medication overuse headaches
mm,
resulting from overuse of various analgesic or even migraine specific medications for acute treatment. So those are secondary headaches, and we'll talk a little bit too about how to tease out or know when to refer on
mm,
for additional evaluation and red flag symptoms. But primary headaches, the key three that you'll see are the tension type headaches, migraine headaches, and cluster headaches. And migraine headache specifically, that tends to be one of the more prevalent, certainly is one of the most common primary headache disorders I see come through my clinic, and has also been really the focus of a lot of medication drug development and research.
mhm,
So for migraines alone, we've had, gosh, in the last decade, 9 different novel medication approvals just for
mhm.
migraines alone.
Wow.
So
Wow.
um, yeah, a lot of exciting time to be a pharmacist in neurology and learning about all of these for sure.
Yeah, for sure. Yeah, for sure. It's sad sometimes that we geek out um when, things get I guess promoted or really kind of shown that they're impacting a lot of people, but yeah, you make a great point because what other disease state can make that claim? I would say very few that, have had that much dedication to new novel medications being kind of developed and studied. So yeah, that's great information to know. Okay, so then you mentioned that migraines were the most common there, and this is where I'll ask potentially a dumb question. I guess I kind of always thought or remembered that clusters were just multiple migraines, but are you kind of made them sound like they're different classifications? Is that right?
It is, yeah.
Okay.
So, you can then, many times you see all of these primary headache disorders then subclassified as either episodic or chronic. And so
Okay.
that may be where some of that thought is coming
Hmm.
from. But
Yep.
yes, cluster headaches are their own separate primary headache diagnosis. And this is all outlined from the ICHD-3 or the International Classification of Headache Disorders, the third edition. That's what is our gold standard for diagnosis criteria.
Okay, great. Yeah. All right. So now that we've kind of set the stage for primary versus secondary and kind of what fits into those under those additional subcategories, let's talk a little bit about the management and maybe how that's, what are some recent updates or movement in that space, or what are some of the things that we need to know as pharmacists as far as you said multiple new novel products out there? So how have
Right.
they impacted the management and what we're going to be doing from the pharmacist perspective?
Absolutely. And I think maybe focusing on migraine headaches specifically for this next part may
Sure.
be good.
Yes, that
Okay,
sounds great.
great.
Yes.
I mean, in general, for approaching the treatment and management of headaches, I think really the foundation first is to know there are two arms to headache management. So we
Hmm.
have our acute treatments, which are those medications we are often prescribing on a as needed basis, with the goal of bringing acute relief. Ideally freedom from pain, relief from
Hmm.
headache, but at
Hmm.
least an ability to return to function and a lower intensity of the headache pain. um, Managing acute symptoms along with that. So with migraine, we can see a lot of nausea,
Hmm.
vomiting, sensitivity to light, sensitivity to sound, and many others. So that's one whole arm, acute treatment of the migraine itself.
Okay.
But then the other treatment path that we have to consider is preventive treatment. And so this is usually with a routine scheduled medication, which could be a daily basis, or we have some of these newer medications on a monthly or a quarterly basis,
Okay.
with the intent of preventing the migraines. And so what we're looking for from this treatment arm is a reduction in headache frequency, a reduction in overall headache and migraine days in a month.
Okay.
So I think going into treatment, it's important to know those two different sides of the coin. Many
Absolutely.
times I see patients coming to me and are mixing the two. We're thinking some of our preventive medicines are really they're using it as needed as acute
Uh,
treatments, and vice
mhm.
versa. Others where we're using acute treatments on a daily
Okay.
basis to help manage the headache. So this is a great spot where setting that foundation, having good understanding to the treatment approach to migraines and headache disorders is paramount.
Yeah. And, our podcasts are shorter in time, so we don't have enough time to dig into all the different new novel medications and which ones do what and whatever. That would be a whole nother course. But in general, I just wanted to kind of go back. Um, the ones that you mentioned are monthly or quarterly. Are those injectables? Is that what we're talking about here? Is injectable?
Yes.
Okay.
Well, so, most of the new migraine medications we've had are through a whole new pathway, a whole new mechanism of action. So these are they call them CGRP targeting therapies. And so
Okay.
CGRP, the calcitonin gene related peptide, basically is from the research that we found and what we know is part of the pathophysiologic process in a migraine. So we're trying to block that CGRP rise in activity. And so our medications, we've had some that are approved specifically for acute treatment. So those are often CGRP small molecules, oral tablets that you can take, or one that's a nasal spray that you take on an as needed basis as an acute
Yep.
treatment. And then we
Okay.
have others that are one that's an oral, three that are subcutaneous injections, and one that's an IV infusion that's either on a daily, monthly, or quarterly basis depending on
Wow.
the dosage form for migraine prevention.
Okay.
Um, and one medicine that's the first and only migraine medicine approved for both. You can use it for acute treatment and can be a preventive agent.
Okay. Great. And is the dual one, is that what formulation is that?
It is actually an ODT, a
Oh,
dissolvable tablet. So
okay. Got it.
a whole
Okay.
lot of a lot of new action.
Yeah, that's great. That's a great overview. And, again, we could spend another hour digging into the specifics and each individual, medication and whatnot. But so what I want to go into now is what informs, um, obviously, what guidelines do we refer to when treating and managing migraine headaches? So where are the discussions on what to use, when to use, how to use, that kind of thing?
Absolutely. Great question. Um, and an area of a lot of literature and topics we could discuss further too.
Open the
The
Pandora's box. Perfect.
the last major guidelines that we've had were from the American Academy of Neurology, published in 2002. 2012, specifically for the prevention of episodic migraines. This is where you see a lot of our older medications that are not necessarily FDA approved or specifically designed for migraine, but we know have established evidence for helping prevent migraines. So you think of some of your anti-seizure medicines and your
Mm,
antihypertensives,
hmm.
for example.
Sure.
So 2012, quite a few years ago,
Yeah.
and
I
starting
mean, well,
around
especially since, that's 13 years and you said there's been so many new novel products in the last decade. Like, I feel like there's a
exactly.
missing guideline update.
So the AAN guideline update is in progress, but have not heard a release date on when we may expect that to be out in
Got it.
circulation yet.
Got it.
But really to address that, yeah, we've had quite a few different organizations that have put out guidelines, or position statements, consensus statements to try to address where these new therapies may fit into practice.
Sure.
So my practice site is at the VA. You mentioned the VA DoD clinical practice guidelines. We have had a guideline update for our population. It was published in 2023, an update from 2020, and it comments on some of these newer therapies as well. On the private sector, or more globally, we have the American Headache Society that has published several position statements, and most recently had a publication just last year, specifically addressing how we integrate these new CGRP targeting therapies, and
Mm,
even commenting or almost advocating for considering these options sometimes as first line options.
mm,
Now, those are not formal guidelines. It is still
sure.
a position or consensus statement, so you do need to
Hmm.
take that with a grain of salt. But I think it does give some helpful perspective, and
Yeah.
helps to uh, really help consider this really vast increase in medical literature that we have to sort through and navigate as clinicians to try to decide where these fit in practice right now.
Yeah, for sure. Wow. Yeah, that's a great overview, and it sounds like you're in need, or your division of what you're doing there. You all are in need of those updates and those changes. So hopefully that's coming soon. Um, so let's segue into what is the role of the pharmacist here? Like what are we positioned to do as pharmacists in managing headaches for our patients? And you can specifically, speak to migraines if that's really probably the majority, I would assume, of what we would see in practice setting. But I want to talk about what exactly can pharmacists do in this space.
Yeah, absolutely. Well, I mean, just knowing that headaches are so prevalent, I think it's very likely that pharmacists will encounter patients with different headache disorders across multiple practice settings, whether
For
we're in
sure.
the community, whether we're in the hospital, whether ambulatory care. Um, so patient education is very important. We talked a little bit about educating on the treatment approach to migraines, the acute versus preventive
Hmm.
treatment.
Hmm.
One reason why I think that becomes so important is because of the secondary headache that I mentioned earlier, the medication overuse headache, what was formerly known as rebound headache. Many still refer to it as rebound headaches.
I was going to
And
circle back to that because when you mentioned that the meds cause headaches themselves, that was intriguing. So yes, let's go down
right,
this path. Yeah, for sure.
absolutely. And it's kind of counterintuitive for patients. They
Right.
may have found a medicine or even an over the counter or a prescription specific migraine medication to manage those symptoms, and it has benefits. So why not take it on a daily basis, or why not
Hmm.
take it for every single migraine?
Hmm.
So, medication overuse headache, and this is another specific secondary headache that is outlined in those diagnostic criteria I referenced. Essentially, it's a headache that can arise after consistent overuse of acute treatments. And so, this can be different analgesics, whether it's over the counter medications like acetaminophen, ibuprofen, naproxen.
Hmm.
It can be some of our prescription options and some of our migraine specific acute treatments, the
Okay.
triptans like
Hmm.
sumatriptan, rizatriptan, that whole class
Yep.
has been associated with these. Um, some of our other acute treatments like ergotamines. And then acute treatments that are generally not recommended anymore for migraines are butalbital containing products and
Mm,
opioid analgesics. They have an even higher risk of medication overuse headache. So,
sure. Okay.
um, but in general, when you look at those different treatments, for the most part, we're talking less than 10 doses a month. And when we're starting to exceed those numbers, so if you have a sumatriptan prescription for acute headache management, acute migraine, that's why it's often limited to a quantity of 9. So 10 doses
Mm,
or more is where we see that association with medication overuse headache, where it can either cause the secondary headache or the migraine diagnosis that they had as their primary headache maybe can convert into chronic migraine. And it's it can be very difficult to manage once
mm,
we get into this cycle and overusing these acute treatments. So prevention really is the key. And I think
yeah.
that education and kind of like smoking cessation, you ask about it at every visit. I kind of feel like
Mm,
that here with medication overuse headache. Ask about it at every visit. How often are you using it? Try to
mm,
really reiterate those points and provide that education, so we don't get into that cycle and
yeah.
have worsening outcomes.
Yeah, and I mean, pharmacists are well positioned, especially those that have access to the fill data. We can see how often they're filling those medications. I would assume the triptans now, a lot of them have been generic for a while. A lot of them are probably very affordable now. And so some
Right.
patients probably say, "Oh, well, my insurance doesn't pay for more than 9. Well, I'll just pay cash for another refill or something." So I think that would be a red flag in a sense of, are you overusing them? Not a red flag in a sense of, you're committing insurance fraud or you shouldn't be doing this,
Right.
but more of a, again, asking those thorough questions. How often are you actually using these, and providing the education and making sure that they're aware that overuse of them can cause the rebound headaches.
Right.
So that's a great position for a pharmacist to kind of jump in. So
Absolutely.
yeah.
You mentioned red flags. We use sometimes a mnemonic for red flag symptoms for headaches, and one of them does reference painkiller overuse. So we have the Snoop criteria, is what it's referred to sometimes. So
Okay.
that is one of those refer on because they may need a preventive therapy that's added,
Yep.
or they may
Right.
need further evaluation to help get a handle on their headaches.
Right. And this may be opening up a whole different avenue of discussion that would take longer, but how do we rectify the issue of having a rebound headache? Like, are they ever able to go back to using those preventative, or to using those
Yeah.
acute medications, or?
There's some different schools of thought. Many times we're considering a preventive medication. We're at minimum trying to taper down or even taper off of the acute medication
Right.
that is the culprit, and trying a different option. One
Mm,
thing that's interesting to note is that I mentioned the CGRP targeting therapies, the GPANTs that are approved for acute treatment. We have not seen this medication class associated with medication overuse headache. And so this could
mm,
be one place where if you have someone really struggling with this, has tried our standard options, we're not making much headway, maybe this is where we go next with one of these
mm.
oral CGRP inhibitors.
Okay, interesting. But I would imagine that one being new, that it's probably very expensive and possibly not often covered and whatnot. So may run into barriers there. But
Exactly.
again, it sounds like it would be a down the line option. So if they've already kind of quote unquote failed on previous therapies or struggled, then maybe it would be something that could get approved. So yeah, no, that's
Right.
another great place for pharmacists to interject in, and being able to say, with that continuity of care, like, oh, well, they've tried this, this, and this before, so maybe they're a candidate for this. So
Right.
okay, that's very helpful in kind of setting the stage for those rebound headaches. Again, I feel like something that is not really commonly discussed, so I think that's a great key point for pharmacists to educate patients on that phenomenon, and just to make sure that patients are aware and are not overusing. So
Right.
that's great. What other opportunities besides patient education do you see pharmacists have in the management of headache space?
Yeah. Well, I think This is an area where we can make a lot of great recommendations. I mentioned we have so many medications, so many that appear in the guidelines and these updated position statements
Hmm.
for both treatment arms, prevention and acute treatment. And they cross a lot of different mechanisms and a lot of different
Mm.
specialties. And, you may be seeing someone in clinic for blood pressure management and, you're managing their hypertension, but they're also having migraines that have been worsening. So maybe even just knowing what some of the key areas
Mm.
are where we can overlap and use a medication as a dual treatment for
Yeah,
those different comorbidities, try to minimize polypharmacy.
yeah,
Um,
absolutely. Yeah.
Certainly is an opportunity where I think pharmacists can jump in and use that drug knowledge.
Yeah, for sure. And we touched on, I think we didn't speak to it specifically, but adherence, obviously, and again, the education on when is it appropriate to use a preventative versus an acute, and those kind of things, and then watching for the refill data and determining, are they adherent and whatnot. You mentioned earlier, and this is something I want to go down this path. Before our time runs out. I swear, I'm going to extend these podcast sessions. I say every time, like our time just comes to an end so quickly. So one thing I wanted to go down the path of and just briefly discuss again, because you mentioned it, there are often some side effects from the medications themselves, right?
Right.
But there are also other side effects that they're treating other than the headache itself. So let's talk briefly about that and how the medications play into that and what pharmacists can maybe
Right,
offer.
absolutely. Well, I think a huge takeaway point, and this has also been consistently reiterated in guidelines and position statements, is that headache management is not a one size fit all approach.
Mm.
Every
Hmm.
patient is so unique in how they may respond to a different medication, how
Or
they
how
may
they present.
tolerate a different
Mhm,
medication. So I think you have to go into each unique situation, each unique patient with that in mind and treat that one patient. Know that
mm,
we've got this now plethora of different options from both non-specific and migraine specific to even a lot of new non-pharmacologic and neuromodulation devices and different options for management. So you have to find what is going to meet the patient's goals, where can we minimize drug interactions, where can we
mhm,
prevent those side effects, or maybe where we can provide some overlapping benefit.
mhm.
That's really is what I love about my job. It's kind of every day is a little bit like a puzzle. How can we
Yeah,
make a bigger impact with one small adjustment?
yeah,
um,
yeah.
that goes even down to the dosing. With preventive medicines, this is something I tell my learners when they're on rotation all the time. When you're thinking about an adequate trial of preventative medicine, you need to ask yourself, did they get to the right dose? Were they there for the right amount of time? Right dose, right
Mm,
time.
mhm, mhm,
And so sometimes that titration needs to go slower for some patients. Maybe we need to target a lower dose or a little higher dose. And
mm.
did they have an adequate trial to really give that medicine a fair shot of working? So I think
Yeah,
those are also questions you can kind of ask yourself if a patient is showing up and saying, "Oh, I started this topiramate and I've been taking it for 2 weeks. It's not doing anything." We need to know that that's not an adequate trial. That's not
right,
enough time to see that
right.
benefit captured.
Yep.
Um,
And
so
again, another great place for an interjection from the pharmacy team, and with that continuity of care, collaborating with the other providers, making sure that they're aware. They only took this for 2 weeks. That probably wasn't sufficient. Before you just start jumping around to another medication choice. So yeah,
right.
yeah.
Since I gave you my go-to for preventive medicine, I guess I'll give you my one-liner for acute treatment. I tell learners, hit it hard, hit it fast.
Mm,
So that's another consideration. Sometimes, you may be having someone coming in treating with the 325 milligram of acetaminophen. That may not cut it for a
mm,
migraine of moderate severity, so we may
sure.
need to hit it with 1000 milligrams. So hit
Mhm.
it hard, hit it fast. Another key education component is these acute treatments are going to work best if you can take them right away at that first sign of a
Yep.
migraine presenting,
Yep.
or even sometimes in that aura phase or
Aura phase.
prodromal
Mhm,
phase. So
mhm.
hit it hard, hit it fast, get it in quick for best response. And so
Yeah,
that's another place where I think we can support and provide that education for patients that may optimize their medication's effectiveness.
yeah, that's great. That's great. Well, I still have a lot of things on my list. I'm going to just have to have you back for another episode. So, briefly, we can talk just quickly. Are there any challenges or barriers that you've seen in managing headaches that you want to kind of touch on or share any kind of tips or tricks about?
Right. Well, I think we've covered a lot of the big
I
ones.
think it kind of, yeah, we've kind of gone from the opportunities and talked about the challenges and how to overcome them. So I feel like we've
Right.
probably hit things. Yeah.
Managing
Um,
the medication overuse headaches sometimes can be a big challenge, like
Super challenging.
that
Yeah.
perception coming in of needing that acute treatment and having to, think about those motivational interviewing techniques and that shared making process to try to reframe our goals and expectations. So that may be one challenge I'll just kind of reiterate
Yeah.
that you may
And to be
encounter.
fair, it's not logical. It's not logical, right? Like it doesn't even
Mhm.
like the fact of the medication you're taking to treat your headache might cause a headache. Like that so I can see where
Right.
patients get really confused or lost with that. So that's a great opportunity for the pharmacist to really step in and educate and to support with that. So okay, well, with that, I always like to kick it back to our expert for the day, our guest, and ask you what's our game changer here? What's our take home point for our listeners?
Right. I think the take home overall is that we have to treat every single patient individually,
Mm,
look at each unique case comprehensively, look at what are those specific goals that we're trying to achieve and that the patient has using the shared decision making to
hmm
find the best fit and the best regimen since every patient is so different.
Yeah. So the game changer here is pharmacist. You do have a role. It's a very important role, and you need to be sure that you are individualizing the care for your patients. So yeah,
Absolutely.
yeah, that's great.
Great.
Well, Allison, that's all we have time for. Thank you so much for joining us. This was great. I learned a lot. It's been a while since I've talked about headaches. Yeah. So this was great. Thank you so
Well,
much.
great. Thank you so much for having me.
Yeah, absolutely. If you're a CE Plan subscriber, be sure to claim your CE credit for this episode of Game Changers by logging in at ceimpact.com. And as always, have a great week and keep learning. I can't wait to jump into another game changing topic with you all next week.